Good morning, my name is Enteral. I'm going to be doing my validation for the enteral feeding and nasogastric tubes today. Good morning, sir. My name is Marty. I'm going to be a nurse for today. And what is your name? And your date of birth? Okay, we'll just confirm that with your name tag. How are you feeling today? Do you have any pain? On a scale of 1 to 10, 0 being no pain and 10 being the worst pain ever? Okay, and do you have any nausea, vomiting? Do you have any allergies to medications? Latex, any other medications that you can't take? Sensitivities to the medicine? No? All right, good. We're going to be checking out your belly this morning, making sure your nasogastric tube's in the proper place, and then we're going to do the feeding that the doctor has ordered for you. Is that okay? All right. So just give me a moment to get things set up. Do some hand hygiene, making sure this is an aseptic technique. I'm going to gather my equipment. So I'm gathering my objects needed for nasogastric tube assessment as well as the feeding. I have my feeding bag, my food I'm putting over here. All right, sir. What we're going to do is I'm going to lay you flat and get you up to a workable height first. Then I'm going to lay you flat and check out your belly. Is that okay? All right. And here we go. Let me know if anything hurts, if you have any pain, and we can stop. We'll just lay you flat for just a couple minutes. All right, I'm going to expose your belly so I can take a look, inspect it. Right. Making sure I don't see any discolorations, any obvious distension or abnormalities. I'll have my clothes in place. We're going to be doing a few things, sir. So I've inspected. So I'm going to percuss your belly, starting with the right lower quadrant. You said you had no pain? Okay. I'm listening for tympani. All right. Sounds are normal? Good, excellent. I would have auscultated first. Inspect, auscultate, percuss, and then palpate. So inspect, auscultating, I'm going to do the assessment for 1 minute each quadrant, starting with right lower quadrant, looking for 5 to 35 clicks or gurgles per quadrant. If there are no sounds or less than normal, then I would listen for 5 minutes for each quadrant. Okay. Once I finish the auscultation, then I would be doing percussion. Looking for tympani. All right, and everything's good. Then I'm going to palpate. Let me know if you have any pain. I press. And checking for rebound tenderness, any masses, rigidity. Okay, and now I'm going to go a little bit deeper, feeling for the organ edges, borders, any masses, things of that nature. Okay, things are going well. Excellent. I'm going to cover you back up here. And now we're going to sit you up, sir. We're going to go up to about 30 to 45 degrees. And then we're going to check to make sure your NG tube is in the proper place. Excellent. So it's between 30 and 45 degrees currently. So in order to measure for somebody who's having a new NG tube placed, I would take the appropriately sized NG tube, and I would measure from the xiphoid process in the adults up to the ear, and then I would come around to the nair and measure the depth of that. At this point, it's 70 centimeters. I would mark it with a Sharpie or a piece of tape so that I would know how much to insert it. And once it's inserted, the patient would have to be sent off to X-ray for confirmation to make sure it's in the proper placement, not in the lungs or intracranial placement. This is a pre-existing NG tube, so we do know that it was confirmed by X-ray. Now we're going to make sure it's in the proper place and hasn't migrated. So we're going to do a few things for you. First, I'm going to put down a chuck to make sure we don't get any contents on you, just to make sure things are okay. And I'm going to set down a chuck on my table as well to catch anything that may perchance spill. Syringes, got my litmus paper, got my medicine cup. So initially, I'm going to take the tube, I'm going to inject up to 30 milliliters of air into the blue section, remembering that blue gets the O2. Inject it. Okay. Once that's injected, I'm going to switch to the clear side, and I'm going to aspirate 5 to 10 milliliters of fluid, checking for the color, looking to make sure it's a yellowish but not too deep a color, and looking for the viscosity. Clear fluid would be indicative of pleural placement. Too viscous, maybe gastric intestinal placement. I'm going to inject the fluid, the aspirate, into my medicine cup. I'm going to take my litmus paper. I'm going to dip it, immediately remove it, allow the excess to drip off, and I'm going to immediately check it, knowing that proper placement of the NG tube would indicate a pH of 5.0 or less. Anything greater than 6.0 is most likely in the intestine or in the lungs. And this is good. It looks to be between 4 and 5, so we have good placement. Once that's been confirmed, I'm going to measure the residual gastric volume. So I've got my calibrated cylinder. I've already inserted 30 cc's of air previously, so I don't have to necessarily do it this time. If I hadn't checked for that, I would have injected 30 milliliters of air to make sure I'm not against the gastric wall. At this point, I've connected it to the clear tubing. I'm going to aspirate the contents slowly, making sure I don't cause discomfort to my patient. And I'm going to remove all the aspirate contents and place it into the graduated cylinder, continuing until I get no further aspirate. I'm going to measure the amount of aspirate, hoping that, checking to see that it's less than 250 cc's. Anything greater than 250 cc's or milliliters, I would have to notify the doctor that there was decreased elimination of the food or gastric contents. And once that's done, I've measured the appropriate amount, I'm going to return the gastric contents to the patient's stomach. And I will do this by taking the back off of my syringe, connecting it to the NG tube, and I will pour the contents back in. If it goes too fast, I'm going to lower the level of the NG tube, making sure it goes at a slower amount so it doesn't cause discomfort to the patient. And once that's done, I will keep that, remove, or actually I could leave this in place and pour 30 cc's of sterile water in there to clear the fluid, or I could take a fresh syringe with sterile water, inject 30 milliliters of fluid to make sure it's clear. Connect that back up. How are you feeling? Okay, I'll make sure that's taken care of. Once this is done, if I'm going to be giving an enteral feeding, I'd make sure I have my bag for the nutrition. If the doctor ordered a specific enteral nutrition, I would check to make sure for the proper name, proper ratio of electrolytes that may be listed, making sure the date's within the proper time frame. With an open system, I'm going to open the covering. And I would open up the sterile cover, pour it in, having the roller clamp closed, fill it up to the level that needs to be, that was ordered for the enteral feeding. If it was a metal can, such as Jevity or some of the other ones, I would want to make sure I wipe the top of the can with an alcohol wipe to make sure it's clean. Once this is filled to the proper level, put the cover back on, hang it up, and flush out the tubing until it's completely bled through. I would hook it up to the pump if necessary, and I would connect it to the patient's NG tube. And then I would make sure the feeding goes to the appropriate time. Once the feeding is complete, I'd want to remove this and inject 30 milliliters of fluid to make sure, or sterile water to make sure that it's clear, and finish emptying the contents into the gastrum. Connect that back up. The patient would have to be maintained at an elevation of 30 to 45 degrees for at least an hour afterwards to make sure there's proper gastric emptying contents. Another way that we could do a feeding is by taking a sterile syringe, removing the back, and connecting it just like we did when we administered the rest of the gastric reserve volume. So I would take my food contents, open up the sterile container, and pour it. I would have the ability to kink, pour it up when the syringe is about 3/4 full. I would allow it to start emptying into the gastrum, making sure the food is room temperature. And once it goes down to about 1/3 to 1/4, I would continue emptying the feeding until it finishes being administered. If it goes too fast, I'll lower the level so it goes to a slower amount so the patient doesn't experience any discomfort. Once that's finished, I would take my sterile saline or a syringe, inject it in and to allow it again for the cleaning of the tubing. Once complete, disconnect the syringe, reconnect the ports so that there is no leakage. I would remove the chuck, get rid of it, and I would make sure that the NG tube is secured to the patient's johnny, making sure I do not use a safety pin. I would use a clamp to make sure. And make sure the patient is comfortable. How are you feeling? I'll lower the bed to the proper height. And again, I'm going to maintain it at 30 to 45 degrees for at least an hour afterwards. Thank you.